Alright, so basically my presentation today is about post-Guillain-Barré syndrome in an orthopedic setting, how patient values, biomechanics, and neurology are integrated. And before we begin, I kind of want to give a quick background information on what Guillain-Barré syndrome is, right? So it's an autoimmune disorder of the peripheral nervous system affecting the Schwann cells, right? And so this results in primary demyelination of the axon, which can lead to degeneration such as Wallerian degeneration of the distal axon. And this can lead to progressive weakness of the muscles, and it can also lead to diminished and absent tendon reflexes. So again, this is the peripheral nervous system, so we're thinking lower motor neurons, so we're thinking decreased and diminished reflexes. So let's talk about the purpose of my presentation, the purpose of why I did this project, and essentially it's to offer a potential of self-learning through metacognition, through self-reflection and input from others. It's also to demonstrate the integration of neurology and orthopedics, how they're two sides of the same coin. You essentially can't have orthopedics without neurology, you can't have neurology without orthopedics. And I'm going to demonstrate that, that's my goal. And also to offer opportunity to highlight my clinical problem-solving process, right? So let's go to my patient. So she's a 43-year-old female who originally came with low back pain, low back spasms after carrying her 25-pound dog and walking. So she reported 5 out of 10 on the visit, but her pain was up to a 9, 10 out of 10. And essentially, what would aggravate her symptoms, what would aggravate her low back pain, was that walking long distances, specifically greater than a mile. Squatting would also aggravate her symptoms because she would get unsteadiness and shaking of the knees. And also bending over for repetitive amounts of time would also result in increased low back spasms, and also carrying her dog or even groceries as well. These are things that aggravated her symptoms. Things that eased her symptoms was rest, of course, and she was also taking medications like Flexeril, which was a muscle relaxant, and so that kind of helped ease the spasming and easing the low back pain. And also she was getting neurological massage. This essentially was just like a massage for the low back. And again, since we're dealing with low back pain, I had to ask special questions, right? Did you have any changes in weight in the past 6 months? Any changes in bowel, bladder? All those were negative. No tremulous sensation with the saddle area, and also no referral of symptoms below the knee. So all those were negative. Yeah. So she also, another big complaint that she had was a fear for falling after walking long periods of time, especially like walking on hills. She was not able to do that due to fatigue and unsteadiness of her knees. So now let's consider her past medical history, right? So she had a severe acute onset of Guillain-Barré syndrome in 2001, where she was wheelchair bound to 2002 and 2004. She also had a history of interstitial cystitis, history of depression, which she was taking Elavil for medications, but she was no longer taking it. It's also a history of anxiety. So let's move to her goals. So her goals essentially was to walk longer distances with decreased fatigue. Her main complaint was fatigue. She also would like to be able to pick up her dog and walk her dog with no results of low back pain and spasms, right? And also carrying her groceries as well. She also wanted to walk and carry her dogs without unsteadiness of the knees. She didn't want to have that feeling, that fear of falling. So these were her goals. So now let's talk about, since the clinic that I worked in was very biomechanically focused, we began with observation of the static posture, right? So a static posture, her feet were in a pronated position, just in static stance, and then with squat, with a functional squat, the pronation would increase. It was an increase in pronation in the ankle. And then with the knees, she was in the static posture, she was in the flex posture. She had difficulty keeping the knees straight, just with static stance. And knees were also in a genovalgum position. The knees were kind of internally rotated. And also interrotation of the hips was also noted. With the squat, the eccentric phase of the squat, you saw a lot of shaking, a lot of unsteadiness. And in the concentric phase, which you saw, you didn't see a smooth contraction into knee extension. You actually saw like rather a choppy contraction towards getting towards knee extension. And again, this relates back to the health condition because of the demyelination and then not the smooth tendinium contraction. So with hips, so measuring the ASIS and PSIS iliac rest, the left side was lower. And then with squats, she had an increased hip hinge. And one of my possible hypotheses, just from without doing any examination, just from looking at that, I was like, maybe she's trying to compensate with the hip hinge because she's not able to bend her knee as far due to the weakness in the quadriceps. That was just a hypothesis at that point. For her spine, she was more in the hypokyphotic position, and thoracic, it was hypokyphotic for the thoracic spine and hypolordotic in the lumbar spine. So now let's look at function. So this is the most important thing, right? So gait analysis. So with her feet, so we begin with the feet. So walking forward, you saw increased dorsiflexion into that terminal stance, basically decreased forward control of movement. So one possible hypothesis is it the plantar flexors, is it the calves that are not, like strong enough to control that forward movement. This is just a hypothesis at that point. The knees also, she was in knee flex posture from that heel strike all the way to that stance phase of gait. She wasn't able to keep that knee into like even close to extension. It was more in that knee flex posture. And also, for the swing phase was actually pretty normal. No problems with the swing phase gait. With the hips, she had decreased hip extension and also Trendelenburg sign on both hips bilaterally. So now let's look at movements. So spinal movements, lumbar, flexion, side bending, rotation, and extension. All those were within normal limits. No limitations there with movements, with active range of movements. The only limitation that I did find was extension. So I actually kind of messed up on the slide, but it was decreased extension on both sides, with the right and the left hip. And also with strength, in terms of strength, greater weakness was noted with external rotators, adductors and extensors. More significant weakness on the left side compared to the right. Knee range of motion, ankle range of motion were all within normal limits. And so for the neurological part of my examination, so I took the myotomes. So the L2 hip flexion, nothing really too noteworthy of noting, except that 3 plus out of 5 on the right side. I didn't primarily focus on hip flexing on the hip flexors on the right side due to the it wasn't really affecting her function as much as that part of the examination. So then we looked at L3, so like knee extension and hip adduction. Again, weakness was more noted on the right side compared to the left side. And so you actually saw more shaking, more unsteadiness on the right side compared to the left side. So I put my qualitative data there as well. So this wasn't the manual test, but this is just a quality for knee extension. You saw decreased activation of the right distal quadricep, the distal VMO, distal VL, and the rectus femoris in the right knee compared to the left knee. So the big things to note was the pattern of weakness with L5, like the hip abductors, eversion, big toe extension. There was a pattern of weakness with there. So definitely there might be some myotomal involvement there. And also S1 as well, plantar flexion, was not able to do a heel raise at all in stance, was only able to do it in gravity limited position. And with hip extension, like we said before, was 3 out of 5. So considering those, 2 plus out of 5 was the myotomal strength that I gave for her. And then with the prone hip extension, also the quality of hip extension from the prone position, I saw decreased activation of the glute max and multifidus, but also increased engagement of the hamstrings, which is probably one of the reasons why S2, like knee flexion, was fine, like 4 out of 5. Was more on the weaker side, but it's still fine compared to everything else at that point. Dermatomes were all within normal limits. S1 was something, reflex was something important to note because I was unable to list the reflex. And again, let's go back to my neurological findings of the myotomes. The most findings we saw was S1, plantar flexion, hip extension. That relates to the decrease in reflex, in Achilles reflex with S1. So S1, you can see, was more involved, I guess, from that level. So palpation, your CPM, if you guys took orthopedics, with Dr. Smith, your condition, your position, your movement, right? So the condition of the palpation, very tender, lumbar multifidi, the paraspinals, the quadratus lumborum, the upper glutes, very, very tender. So then the leg length discrepancy test, it was negative. So it was negative for that, normal spinal alignment, position. And then when I did the movement, so the anterior glide of the hip, because it was limited in hip extension, I had a firm end field, so no problems there. The normal movement of the facet joints, and the reason why I checked the facet joint motions, even though the movement was, the active range of motion was normal, was to see if I can reproduce any pain. I wasn't able to reproduce any pain with the said joints testing. So now let's look at our special test. Positive Thomas test on the right to see. I just wanted to see if there was any tissue involvement, and rectus femoris was more involved in the iliopsoas on the right side. So she also reported a pelvic pain. I did the SI joint compression test and distraction test. Both were negative. The 90-90 test, I did not do that test because it was actually the person who actually did the eval. He did that test, but I just included that here. And he also did the straight leg raise test, and that was also negative. So the outcome measures that I use. So Guillain-Barré, one of the important things to note is that it seems patients who have Guillain-Barré syndrome seems to be most impacted or affected in their ability to participate in work, family, and social activities. They also tend to have greater anxiety and depression compared to the normative population. So now considering that, right, I wanted to find an outcome measure that considered the whole patient as a whole. So that's why from the research that I looked at, I had the short form 36. So this considered, the emotional aspect, the social aspect, the pain, the health, the role limitations. So that was a very good outcome. The only outcome measure, the only problem with this is not specifically validated for neuromuscular disorders. However, it was so useful. I also had a unidimensional outcome measure test, which was the fatigue severity scale. And because one of our main complaints was fatigue, I used that scale, and that's actually had a very good internal consistency, very good test-retest reliability, and very good discriminability with patients with neuromuscular disorders. So I used that specifically. And she had a 7, so 7 was the highest level of fatigue. She had 7 across the board. So she was the highest level of fatigue on that scale. Another outcome measure that I use, I kind of created this one. It's called the speed walking time test. It was just like 3 labs. I measured it in time and I also assessed the quality for gait. And so initially, again, you had that hip internal rotation, the knee in the valgus position, increased pronation in the ankles, and also her hands were kind of like all over the place to help her balance herself. So using her hands as a compensatory strategy for balance with speed walking. So I use that as well as a baseline for cardiovascular endurance and power and gait mechanics. So now let's look at evaluation. So evaluation, so we have to consider the ICF model, right? And since one of our main complaints was fatigue, one of the studies that I looked at incorporates fatigue in a multidimensional aspect. So fatigue is not only the physiological fatigue, right, that you expect in impairments, right? But it's also you have to think about experience fatigue. So like in activities and performance and participation with your friends, with your family. This is also like a social aspect of fatigue. So we need to consider that as well. And that's why I wanted to show you guys this picture. So now let's look at the HiPAP model, the health condition. Why is it important? It essentially gives us an understanding of what we see and why we see it. So what we see impaired maximal force. And the reason why we see, so like for example, the impaired maximal force on the right knee extension compared to the left, right? The reason why we see it is, partial denervation. And this is related to the health condition, right? Secondly, the health condition is important because it gives us an understanding of how to progress and how to modify treatment, right? Patients who have Guillain-Barré syndrome, one thing is fatigue of central origin. This is the overburdening of input to the central nervous system. So now there's a mismatch of information between the right side and the left side. All the sensory information is being sent to the brain, and so the brain has to figure out how to compensate it. So what they do, the brain is trying to send the information from the sensory cortex to the motor cortex to recruit more motor units. And what that does is it doesn't realize the health condition as of yet. So what happens is it kind of overburdens and recruits the maximum amount of motor units, which it's not able to recruit, right? So it leads to even more fatigue. The cycle continues, and it amplifies the sense of the weakness and fatigue. However, luckily we have the central governor model, which is a protective mechanism in the sense that the fatigue is a signal for the body to minimize its activities in order to not overburden the motor system or the neuromuscular system. Because one of the studies also showed that if you overburden due to like overwork, you can actually regress in terms of strength, in terms of strength and progression. So the implications, again, is to watch out for overwork and watch out for fatigue. So the impairments of the HiPAP model, I already talked to you guys about the range of motion and the strength and the fatigue aspects, so we don't really have to go over that again. But again, you saw like, the weak hip external rotators as well. So let's go into the activities. So again, fatigue was her main concern, and that was affecting her stair climbing. She wasn't able to walk hills. She wasn't able to walk long distances. So this was affecting her activities in that aspect. In terms of participation, she wasn't able, to take care of her dog, carry her dog, do housework, going out with her husband, going out with her friends. These are stuff that was affected in her, her participation aspect of life and environment. So she lived in a single-story house, so she didn't have any stairs. So stair climbing wasn't the main focus because she didn't really have stairs. But this is something to consider as well. And personal factors, she was 42, so she was young, she was strong-willed, and she was very motivated. She was ready to, to get better and to improve. So for the diagnosis and prognosis, primary impairment essentially was neuromuscular reeducation. We wanted to improve the muscular patterns, the pattern of movement, and the patterns of motion. And then so for prognosis, one of the studies that looked at what are the poor predictors of patients who have Guillain-Barré syndrome. And so one of the poor predictors is if they're greater than 55 years old. But her onset was way before that, so we didn't have to worry about that. The severity of admission was the second one. So she had a very severe admission, so she was wheelchair bound. Cranial nerve involvement was the third one. She didn't have any cranial nerve involvement. Mechanical ventilation requirement, none of that was required. And axonal lesions, none was noted for that. But also considered from her personal factors, she was motivated. She was adherent to home exercise program. She was adherent to therapy. She did not miss a single session. She would even stay extra time, like if we needed to. And she also had a very good family support. So considering all this, I give her fair, and I think she was doing really well, and I think she will do very well. Plan of care. Essentially, we started with 3 days a week, and we progressed to 2 days a week. And we did for 12 weeks. That was a goal, because most of the studies that we looked at did it across the span of 12 weeks. And so the plan of intervention started with neuromuscular reeducation, so proper activation patterns, the low back of the hips and the hamstrings, and then progressed that to strength training, because strength training was the foundation to get her back to her functional training, so like gait training and stair climbing as well. And so to begin with, one of the things that we did first was manual therapy. So I did soft tissue mobilization for two purposes. One of the purpose, again, was to increase range of motion and to decrease pain, to target the top bands, the trigger points, and all that. But also, it served the purpose for motor control. So you guys know the sequence of motor control, right? It begins with sensation, then it goes to perception, then it goes to choice of movement plan, coordination, execution, and adaptation, right? So the target and the goal of soft tissue mobilization, one of it, was to activate the sensory receptors, especially in the lumbar multifidus, because she wasn't able to get that volitional contraction of the multifidus. So the soft tissue was able to increase that perception, increase that sensation. And here's evidence of transverse abdominis and lumbar multifidus activation is kind of like not normal for patients who have low back pain in the sense that it's delayed or attenuated with those low back pain. So now let's talk about mobilizations. I did mobilizations for the hip, anterior glide of the hip. Even though it was firm end feel, it's actually for my retest, it actually improved her hip extension. So that really worked. Long axis hip distraction. I didn't do that for the sake of range of motion. I did that for the sake of enhancing joint awareness through activation of joint receptors, because I wanted her to be able to perceive, again, to that motor control, where her hip joint was in space to help her with that gait. So it improved that self-perception, improved that sensation perception. And so for neuromuscular facilitation, I did excitatory tapping, and this was to activate as much motor units as possible for the initiation of muscle activity to improve motor control. So right here, I have the components of motor control listed. And neural again. So then foundational strength progression. So we began with hip extension, supine. The reason why I had it supine was because to begin with was to have the mat as a cue, like a tactile cue to help activate her glutes and everything to go into that hip extension. And I use a foam roll like right above her knees so she can actually get some hip extension. And we did pro hip extension, so her butt was kind of in the air, so she had no cueing and she was able to do it volitionally. And then we progressed to bridges, squats, RDLs, and lift chops. So I want to show you guys what lift chops are. So lift chops is what we did in the clinic. So basically you start from the top, and so you bring down, you go like more like this. So you activate the low back, and then going down into the glutes, and then using the low backs, and then using the hips as well to activate the sequence of low back, the glutes, and the hamstrings. And then we did lift chops with rotation. So going from the side, going up, and then, so also we did for the hip abductors, that's the progression that we did, and also the progression for the abs, for the core, abdominal brace, heel slides. You know, we did dead bugs level 1 and level 2 dead bugs. If you guys have questions about what dead bugs are, I'll show you in the end. It's kind of difficult. It's actually really difficult, but I'll show you guys. And also for plantar flexion, we did originally started with gravity neutral position, and we did TheraBand. And then we progressed to calf presses on the leg press machine. So next, we did the functional progression. This was with weeks 4 to 8. So we did step forward and back, and I was giving a lot of manual cues on her knees and on her knees and her hips to make sure that the alignment and everything was correct. We used ski poles to help with the assist on that single leg stance. And then we progressed that to without ski poles, and then we progressed that to speed walking, like that outcome measures that I had. And we did lateral deals in the end. We did for stairs, we did runner stance into single leg stance. So to help with the glute activation, with the hip abductor activation as well. And for cardio, for like endurance in terms of decreasing fatigue, we did seated recreation bike, and we progressed that to the left. So now, like modifications. So again, like I said, modifications are important because patients usually recover with Guillain-Barré syndrome. However, it's been shown that overworking partially denervated muscles can cause further damage, including a loss of functioning motor units, which has been linked to central fatigue. Since you complain about central fatigue, about fatigue in general, we didn't want to do that. So like this is an example of like one of her responses. So like in the bottom right here, the patient reports low back spasms and was unable to bend over to do laundry for 2 days. That means we overdid it. So therefore we regressed in that aspect. But one of the things that I made sure to do in every intervention session is to limit the amount of variables. So I will only change one thing for every intervention. If I change multiple things, then I wouldn't know what caused her fatigue. So I only change one thing. So in that aspect, it was actually related to doing the low lift chops with rotations, so doing it from here. So I changed it. We just went straight to lift chops, and to progress it, I'll show you guys right here. We'll move the hand closer towards the knee, so to increase that moment arm from the center of mass, and then slowly progress it to even outside the knee. So that's how we progressed it. So we didn't want to irritate it or have that same response as she did last time. So for outcomes after the 4, so it was 8 weeks total, but I only gave her the outcome measures from weeks 4 to 8. So the end of that 4 weeks, which was week 8, she had no change in perceived physical functioning, no change in role limitations in terms of health, but 100% change, an improvement in the emotional aspect, 5% change in energy and fatigue, 22% change in improvement in pain, and 25% improvement in health change, overall health. So I thought that was pretty good in 4 weeks, especially because most of this research had 12 weeks, but this was just 4 weeks. So in terms of the fatigue severity scale, at the end of the 4 weeks, she had 6 across the board instead of 7, with a change of 1, and a minimal detectable change was 1.2. So at the end of the 4 weeks, that's not bad. And in terms of speed walking tests, I have 40.98. I forgot to update it. She actually had it down to 37 seconds. So that's an improvement of like 28 seconds. And her speed walking time. And this is, I'm telling you, like big improvement because She was no longer in that knee flex posture. She was able to get the knee extension, no genivalgum of the knee. She was able to recruit her external rotators of the hips to help control the mobility of the knee, decreased forward. So she had improved forward control movement in her ankle, so more activation of her gastroc soleus in order to control that forward movement. So, and also like her hands, which were originally out from here, she was walking like she was running, like speed walking. So like no problems with balance there too. And it's also her pivoting improved as well, in the sense that she was just like straight pivoting instead of going like in a circle and going straight out. So balance definitely improved, improved quality of gait and improved timing as well. So like how intense should I have done the exercises, the interventions? According to the evidence, higher intensity resulted in improved outcomes. But again, you know, we want to monitor the patient's response. The patient response is very important. So now, interestingly, now this is very important, fitness levels were not correlated with fatigue levels. So if a person with Guillain-Barré syndrome had a very, very high fitness level, it did not mean that they had very low fatigue levels. They could have had very, very severe fatigue levels, right? But there was also a dual effect of physical training, in the sense that it improved physical fitness, but also improved the mental domains of fitness. And by this means improving other domains of functioning. So if you were to look at the more like the biomedical model, like, okay, this person's fitness is like decreased, I want to improve this person's fitness level to decrease this person's fatigue level. It doesn't work like that because, again, there was no correlation between fatigue levels and fitness levels. However, if you look more in the biopsychosocial aspect, the attention of researchers and physical therapists provided to a patient, it actually increased their self-confidence and it increased their social aspect of training. So in a sense that increased their confidence and actually decreased their fatigue levels as a result of that. So considering considering this model actually targets not only the primary impairment or the biomedical reason of fatigue levels, right? It also helped improve the whole patient as a whole. And then home exercise program, how I did it, how I set it up was when she graduated with the exercises we did in the clinic, in the sense that, okay, I think we're wasting time doing them in the clinic because I want to progress to more functional things. I had her do those at home because I was like, I want to do more functional things. I want to do more with you. We only had an hour, so I was like, okay, now it's time for you to do these glute squeezes at home. Time for you to do these hip extensions at home. Time for you to do the side lying clams at home. And we'll just progress to single leg stance instead. So that's how we would, that's how I would progress the home exercise program. In terms of limitations, one of the limitations I didn't do the eval, although I kind of, all those findings were my findings, except the two that I mentioned, but I kind of wish I did the eval. And also one of the things I would have changed, I wish I did the outcome measures from the very beginning. I did it like at the halfway point. If I did it from the very beginning, I probably would have a very different amount of change. And more importantly, the outcome measures really helped guided the way I did my interventions for this patient, because it was more multidimensional aspect. And so I kind of wish I did it earlier, so I would have began that from the beginning instead of thinking more like biomechanically from the beginning. But that was just one of my limitations. And another limitation, I wasn't able to do the full 12 weeks by myself, which most of the studies did was 12 weeks. So I kind of wish I did the whole 12 weeks, but kind of finished it 8 weeks. So. Any questions?
How long did she have the low back pain? So you mentioned
she's
in 2001. How long did the back pain?
So yeah, so that's a good question. Actually, she's been having a low back pain since 2013 because she was originally in 2013 she went to get an MRI for a low back pain, and what it revealed was just minimal degeneration of L2, L3, L3, L4. So she's been having it for quite a while.
I'm a little confused about why you were focused on myotomes. You spent some time describing the pattern of weakness and seemed to conclude that it was related to the S1 myotome.
Right.
And yet this patient has Guillain-Barré, diffuse neurologic insult. So I'm just curious as to why you chose that direction.
Well, I did. More importantly was the Guillain-Barré, but the reason why I chose to try to focus the examination towards the S1 myotome was because I just wanted to see if there was any relationships between the nerve root level and her strength level. And so in this case, S1 seemed to be related in terms of reflexes and also in terms of weakness. But again, like it didn't mean that I only focused on S1. I didn't only focus on S1. I focused on like the whole aspect.
Yeah, the same question. So as a follow-up, so what? How did that change your treatment?
It didn't really change.
Yeah, exactly.
Yeah. I was just trying to be very specific just for my findings. But it didn't really change.
Sometimes it can be over-specific.
Yeah.
You ever heard that before? What would you say was her primary impairment?
So primary impairment, I'll go more into the neuromuscular. So neuromuscular re-education, basically, being able to get the volitional contraction of the quadriceps and the normal activation patterns with functional activities such as walking and gait. That was more of my primary impairment. But if you look at her history, she says I can't walk for prolonged periods. I can't walk for prolonged periods of time. So you're probably thinking like muscle performance, like endurance and strength, because okay, after a mile, I get really fatigued. But considering this patient's health condition, right, and the peripheral nervous system being involved, if you just tackled endurance, and this was my reasoning, if you just tackled endurance and you didn't consider the biomechanical aspect, the appropriate alignment of the hips and activation patterns, you wouldn't be able to get. You can improve endurance, but you wouldn't have. In terms of, there would be more problems down the road. I felt like down the road in terms of like activation patterns of the low back and stuff. And also going back to one of the studies that I looked at with low back pain, one thing that was correlated with low back pain was the decrease in activation of the lumbar multifidus and transverse abdominis as your local stabilizers, and then the activation of the glutes following that, and the activation of the hands like that. So this again is the more neuromuscular pattern of activation. So that's why I chose that as one.
So what was the primary impairment for all that?
The neuromuscular re-education.
That's how you treated it. What was the primary impairment?
Instability. Well, no, I don't say instability. Neuromuscular activation. Like,
Sort of control.
yeah, more control there. More control. Any other questions? You guys good?
I think we're living on time, right?